start off with thanking Professor Jacob Thomas and Professor Parimalam Kumar for inviting me to give this talk in this prestigious conference. And I particularly am grateful to Dr. Dinesh Kumar for all his hard work and getting the technicalities right. I'm fully aware that my talk is just before your lunch time, which is nearing. The one advantage of doing a Skype lecture is I will never know how many of you are looking at your watches for my lecture to finish. So I better move on. I have no disclosures. As rheumatologists, we need to have some knowledge of dermatology and the skin lesions associated with joint diseases. So I'll start off with inflammatory arthritis, move on to connective tissue diseases, vasculitis, and then we'll touch on a few of the infrequently seen rheumatology conditions with skin lesions. And, oh, this is not moving. The screen is not moving actually. This is where I work at Chelmsford Hospital, and that's where it is on the map, UK map. Coming to rheumatoid arthritis, it's a chronic systemic inflammatory disease, mainly involving the synovium and the small joints of the hands and feet. It affects 1 to 2% of world's population, more commonly seen in genetically predisposed individuals. As it's a vasculitic condition, there are other major organ complications seen in some of the patients. When they present with multiple joint inflammation, particularly the MCP joint inflammation, they can also have palmar erythema due to increased vascularity with the redness of the palms. Rheumatoid nodule is an area of fibrinoid necrosis with inflammatory cell infiltrates. These are seen on the extensor surfaces commonly, but they can also be seen in major organs such as heart, lungs, and eyes, with some serious complications such as heart block, lung cavitation, and scleral perforation. Commonly, we do see cutaneous vasculitis and nail fold infarcts in these patients. Pyoderma gangrenosum, which is a neutrophilic dermatosis with ulceration, is fortunately seen very rarely these days in rheumatoid arthritis. This is not specific for rheumatoid arthritis, as it can be seen in other inflammatory conditions. We do commonly see adverse drug reactions to the drugs that we prescribe, particularly DMARDs and biologics. Systemic onset juvenile inflammatory arthritis can present with a transient erythematous rash. Kids also present with pyrexia, lymphadenopathy, serositis, and organomegaly. Its adult counterpart, which is adult Still's disease, can also present with evanescent erythematous rash. Again, we are fortunate not to see Felty's syndrome, which is commonly seen in chronic rheumatoid arthritis, predominantly in women, these days due to early treatment. These patients present with splenomegaly and leukopenia or pancytopenia secondary to the splenic enlargement. The common skin lesions we see are leg ulcers due to vasculitis. There is also an association with Sjogren's, and they can present with episcleritis. These are some of the drug treatment that we give for rheumatoid arthritis. The disease-modifying drugs, methotrexate is always number one, and then we proceed to give the other disease-modifying drugs. The list on the right is less commonly used these days. Of the biologics, the 5 anti-TNFs are the start off, and then we move on to IL-6 inhibitors, T-cell modulators, and CD20 inhibitors, depending on the response and adverse reactions. IL-1 inhibitors are less commonly used in rheumatoid arthritis. Psoriatic arthritis, which you are very familiar with, is an inflammatory arthropathy associated with psoriasis. The joint disease can precede skin disease here. Approximately 13 to 30% of patients with skin disease will develop a joint disease develop joint disease in 5 to 12 years. Nail bed and matrix involvement is characteristic of psoriatic arthritis and seen less commonly in patients without overt arthritis. Patients who have skin psoriasis without arthritis may still present with subclinical or clinical enthesitis, that is, inflammation of the tendons and the ligaments at the insertion site. Here, male to female ratio is equal. Most patients present with peripheral joint involvement and particularly distal triphalangeal joints are involved. They can present with asymmetric arthritis affecting the knee or an ankle. And here the differential diagnosis will be septic arthritis or gout. Psoriatic spondyloarthropathy presents sacroiliitis or axial spine involvement is seen in 35% of patients, out of which HLA-B27 can be positive in 15%. Enthesitis, as you can see here, Achilles tendonitis and dactylitis, what we call sausage toe, is fairly commonly seen in patients with psoriatic arthritis. The skin lesions we see with patients presenting with psoriatic arthritis are guttate psoriasis, scalp lesions, erythrodermic psoriasis, flexural lesions, and pustular psoriasis. Anti-inflammatories are particularly useful for spondyloarthropathies. Disease-modifying drugs are very effective for peripheral arthritis, although they do not have much effect on enthesitis and dactylitis. Again, methotrexate tops the list, and cyclosporin is less commonly used. Coming to anti-TNF antibodies, we use the 5 anti-TNF infliximab, etanercept, adalimumab, certolizumab, and golimumab. Ustekinumab is used more by our dermatology colleagues, and more recently it's had license for psoriatic arthritis. Coming to reactive arthritis or ritis, we do not see the classic triad of ritis these days, which is conjunctivitis, arthritis, and urethritis. More commonly, we see reactive arthritis due to gut infection due to Salmonella, Shigella, Yersinia, and Campylobacter. Yersinia reactive arthritis patients present with erythema nodosum. Arthritis is usually acute and commonly asymmetric and monoarthritis. They also present with enthesitis and dactylitis. They can have extra articular signs and symptoms on presentation, conjunctivitis and anterior uveitis, oral ulceration, and they can present with constitutional symptoms. The characteristic rashes seen are keratoderma beloneuralgicum, which is hyperkeratotic skin lesions seen on soles and palms, and genital lesions such as succinate balanitis. Parvovirus B19 infection is another form of reactive arthritis. Patients present with arthritis and arthralgia. The skin lesions are classic erythematous facial rash, which is slap cheek appearance. They can present with papular, reticular pattern rashes on the trunk and limbs. They can also have papular and purpuric rashes affecting the extremities. The other major complications seen here are transient aplastic crisis, fetal loss if pregnant women are contracted with virus during pregnancy, and pure red cell aplasia also seen in immunocompromised individuals. Sacco syndrome, which is also a form of reactive seronegative arthritis, can present with joint synovitis, severe acne with follicular adhesion, palmoplantar pustulosis, hyperhidrosis and osteomyelitis are seen more commonly in sternoclavicular, manubriosternal, costochondral joints. Treatment for reactive arthritis is mostly symptomatic. Some patients may need steroids and disease-modifying drugs. Coming to gout, which is also an Inflammatory polyarthritis due to monosodium urate crystal deposition. They present to us with acute attacks or sometimes with chronic articular gout. Skin lesions are due to accumulation of urate crystals in the form of tophi, which we commonly see in the DIP joints and in the thinner of the. Sometimes these can ulcerate, exuding uric acid crystals. Chronic nephropathy is seen mostly in patients with comorbid conditions. Treatment is with diet, uricosuric drugs, and xanthine oxidase inhibitors. Systemic lupus erythematosus, initially described as only a dermatological condition, lupus meaning wolf, as the facial lesions resemble wolf's bite. Women are more commonly affected. The concordance rate in identical twins is far higher than the non-identical twins. It's more commonly seen in African American and Oriental Asians. Clinical features are mainly due to inflammation of various organs. Skin and mucous membrane involvement and joint involvement is fairly common, with other major organ involvement seen less commonly. They can also present with constitutional symptoms such as severe fatigue, headaches, and weight loss. Arthritis is usually non-erosive, usually symmetrical and affecting small joints of the hands. Deformities here are due to tendon inflammation and contractures. Occasionally joint subluxations are also seen, and they may present with Raynaud's. This is the classification of cutaneous lesions that we see in rheumatology. Acute, when they present with butterfly rash, generalized erythema or bullous lesions. Subacute lupus, when they have annular or polycyclic rashes or psoriasiform rashes, as you can see here. Chronic lupus is localized discoid or generalized discoid. Lupus propendus is with extensive panicleitis. These are some of the non-specific lesions that we see in patients. Commonly we see vasculitis, oral ulceration, and non-scarring alopecia. This is the evolving spectrum of SLE. All of these can present with skin lesions and joint disease. Latent lupus is when patients do have symptoms and signs of lupus, but without having any autoantibodies. Drug-induced lupus is seen less commonly in less than 5% of the total lupus population. It's usually mild and organ complications is not seen in these patients. 90% of patients with drug-induced lupus are due to these drugs. I would like to mention minocycline, which is used for acne, can cause drug-induced lupus, and we see this fairly commonly here. The antibodies are ANA and anti-histone antibodies. Usually the double-stranded anti-DNA antibodies are negative in drug-induced lupus. Antiphospholipid syndrome, which is a subset of lupus, can present with venous and arterial thrombosis and recurrent pregnancy losses. The classic skin lesions are recurrent leg ulcers, but we see libido reticularis more commonly in these patients. They can also present with thrombocytopenia and hemolytic anemia. Anticardiolipin antibodies are usually positive, either IgG or IgM, and lupus anticoagulant can also be positive in these patients. Treatment for joint disease is with the hydroxychloroquine. Low-dose aspirin is required if they've had minor thrombotic events. Heparin and warfarin are reserved for recurrent pregnancy losses and also for major thrombotic events such as stroke. Autoantibodies seen in SLE. ANA is very sensitive but less specific for lupus. Anti-double-stranded DNA is 70% sensitive and highly specific for lupus. The one other autoantibody I'd like to mention is minocycline-induced lupus. They can have transient perinuclear ANCA. Treatment is with antimalarial and disease-modifying drugs. When we proceed to biologic treatment, it's rituximab and bedilimab. Rituximab is particularly used for patients with lupus vasculitis. Coming to dermatomyositis, again a condition with a lot of skin involvement. Gorton's papules, which are erythematous thickened lesions seen in the DIP and the PIP joints, less commonly in the MCP joints. Heliotrope eruption, a bilateral lesion around the eyes. Facial erythema, poikiloderma, stir or shawl sign depending on the skin distribution. And these are photosensitive rashes. They can present with generalized erythroderma or periungual abnormalities, calcinosis cutis, or psoriasiform changes. As rheumatologists, we see them with proximal muscle weakness and interstitial lung disease. There is an association with malignancy and esophageal disease such as dysphagia, and cardiac complications are less commonly seen. We do muscle enzymes, EMG and muscle biopsy for diagnosis. ANA is again positive in these patients, non-specific. Some patients may have anti-SRP and anti-MI2 positivity. Antisynthetase syndrome, which is a subset of dermatomyositis and polymyositis, seen in up to 30% of patients. These patients present acutely with constitutional symptoms and proximal myopathy. They also can present with Raynaud's phenomenon. The characteristic skin manifestation is mechanic's hand, where skin is roughened, thickened, fissures, and cracks, mostly on the radial side of the hand. Arthritis we see here is usually non-erosive, but interstitial lung disease can be a major complication in these patients. Anti-Jo1 antibodies are usually present in these patients, which is antibody to T-RNA synthetase. Systemic sclerosis, again, multiple skin manifestations that we see in these patients. Scleroderma, the word came from the Greek word scleros, which means thickened, hardened skin. The skin manifestations are morphia, which can be either circumscribed or generalized. Here's scleroderma, which the morphia is the linear form. Oncodesebrae, which is seen on the central forehead, like a cut with a sword, is also a form of linear scleroderma. They can present with nail fold in Fox or Raynaud. Ductate morphia is where they have hypopigmented patches, and morphia profunda with deep dermis involvement. Antibodies to DNA topoisomerase II can be positive in extensive morphia. As rheumatologists, we see them with limited or diffuse cutaneous systemic sclerosis. Scleroderma sine scleroderma is when they present with visceral involvement in vasculitis without any skin sclerosis. Environmentally induced scleroderma is due to toxins such as vinyl chloride, pesticides, and resins. Overlap syndromes tend to run a milder course when systemic sclerosis overlaps with SLE or polymyositis. Anticentromere antibodies are seen in limited disease, which we call CREST syndrome. Anti-PMSEL and anti-scleroderma 70 antibodies are seen in diffuse cutaneous scleroderma. Anti-RNA polymerase 1, 2, and 3 may also be present in these patients. Eosinophilic fasciitis, which is another autoimmune connective tissue disease. These patients present acutely with symmetrical non-pitting edema of the extremities, symmetrical erythema and induration with puckering in their extremities, neck and trunk. The skin of the hands and feet are generally spared in these patients. They always have peripheral eosinophilia, and inflammatory polyarthritis is seen in 40% of these patients. As you can see, the classic group and orange sign are due to skin induration. Treatment is with immunosuppressives and immunomodulatory drugs. Coming to vasculitis, we see skin manifestations in small vessel vasculitis, either immune complex small vessel vasculitis such as cryoglobulinemia, inoculation and hypercomplementemic urticarial vasculitis, or with ANCA as associated small vessel disease such as microscopic polyangiitis and Wegener's granulomatosis. In Kawasaki's disease, which is a medium vessel vasculitis, we do see patients with desquamation of skin in the soles of the feet and hands. Patients with vasculitis usually present with systemic symptoms and joint pains. Cutaneous lesions can vary anything from palpable purpura, as you can see in polyarthritis nodosal, or ulcers to skin necrosis. Severe necrosis such as this is seen in microscopic polyangiitis. The other major complications which we tend to treat as rheumatologists in combination with the specialties is renal insufficiency, CNS involvement, and pulmonary and ENT involvement. Nasal crusting and pulmonary hemorrhage are commonly seen in Wegener's granulomatosis. These are some of the investigations, including PET scan, that we do for patients with vasculitis. Treatment is in 2 stages. Remission induction is with corticosteroids, cyclophosphamide, and rituximab, and maintenance is with disease-modifying drugs. Cryoglobulinemia, which is a small and medium vessel vasculitis due to cryoglobulin-containing immune complexes. Here there is precipitation of blood proteins at temperature lower than 37 degrees. There is a primary and a secondary form. The secondary is due to a hepatitis C infection and may be associated with connective tissue diseases. Skin lesions we see are erythematous macules, purpuric papules, libido reticularis. Patients can have post-inflammatory hyperpigmentation, but we do see very commonly gangrene and acrocyanosis in these patients. They present to us with arthralgia, arthritis or myalgia, or with Raynaud phenomenon. Again, renal involvement and CNS involvement is common due to vasculitis. Behçet's disease, again a vascular lesion. The vascular lesions present with phlebitis or thrombosis. We see them with severe joint pains. The skin lesions are characteristically recurrent oral and genital ulcerations. Papillopustular lesions and erythema nodosum is fairly common. Pseudofolliculitis with acneiform nodules are not uncommonly seen in these patients. Eye lesions can be vision-threatening. Pathology test, which is a membership exam question, are not specific for Behçet's disease. With the sterile needle prick, within 48 hours, patients can develop red papule, pustule, or ulceration. Again, neurologic patients can have sinister effects. Urticarial vasculitis. The skin lesions are erythematous urticarial papules, plugs, and wheals. They can be pruritic, painful, tender, burning, and mainly a residual hyperpigmentation. The 2 types of urticarial vasculitis syndrome vasculitis that we see are hypocomplementemic vasculitic syndrome due to C1q deficiency and leukocytoclastic vasculitis. Musculoskeletal manifestations are arthralgia, joint inflammation, and particularly we see substernal pain in these patients. Again, renal involvement and eye involvement are not uncommonly seen. Relapsing polychondritis. This is an immune-mediated vasculitis where there is inflammation in the cartilaginous structures affecting the ears, nose, eyes, joints, and respiratory tract. They may be in association with connective tissue diseases and myelodysplastic syndrome. Skin manifestations are several, starting off with oral ulceration, purpura, libido reticularis, urticarial papules. Erythema elevatum ditinum, as you can see here, is raised plaques or nodules which are usually red, violaceous, or yellow in color. seen on the external surfaces. They can also present with superficial phlebitis, sterile pustules, and ulcerations. External joints, postural joints, and manubriosternal articulations are commonly involved, but we do see them with peripheral joint involvement in 50 to 70% of cases. Treatment is with anti-inflammatories and disease-modifying drugs. Dapsone plays a major part in the treatment. Some of the patients may need specific treatment for their skin lesions. Sarcoidosis, which is a multi-system disease with non-caseating granulomas. In rheumatology, we see them either with acute or subacute disease when they present with ankle periarthritis, hilar tendinopathy, and erythromelalgia. But we do see sarcoid patients with chronic arthritis and sarcoid myopathy. They can also present with dactylitis or vasculitis. The cutaneous lesions are erythema nodosum, as I've already mentioned, maculopapular sarcoidosis affecting the face and eyelids, subcutaneous hypo or hyperpigmented patches, plaque sarcoidosis, as you can see here, lupus pernio, which is an indurated erythematous chronic rash seen particularly in the nose, forehead, ears, and cheek. They can also have atrophic or ulcerative lesions. Lyme disease, which is due to tick-borne illness. The organism Spirochete, Borrelia burgdorferi. The classic skin rash disease is erythema chronica migrans. Commonly, this is simple, or it can be multiple in some cases, depending on the number of tick bites. Arthritis is seen in 7%. They can present with facial palsy or aseptic meningitis. Carditis is rare. Treatment is with antibiotics. Fabry syndrome, the prevalence is 1 in 17,000 to 1 in 100,000. This is the second most prevalent lysosomal storage disorder, seen in X-linked inborn. It's an X-linked inborn error in the glycosphingolipid metabolic pathway. As rheumatologists, we see them with severe neuropathic or limb pain, and there are characteristics cutaneous manifestation, mainly telangiectasia or angiokeratomas. Dermatologic manifestation is seen more commonly in more than 70% of patients at the mean age of 17 years. They can present with renal manifestations such as polyuria or polydipsia, or with gastrointestinal symptoms. They are intolerant to heat, cold, and exercise. Ehlers-Danlos syndrome, which is a genetic disorder of connective tissue, seen in 1 in 5,000. As rheumatologists, we see joint hypermobility with tendon inflammation, ligament inflammation. We also see them with joint subluxations. Cutaneous manifestations are skin hyperextensibility and paper tissue, thin sunken scars second to minor injuries and easy bruising. These patients quite frequently have mitral valve prolapse. Finally, coming to treatment-related rashes, chronic gold treatment with gold injections, they can get a grayish discoloration of the skin called chrysiasis. This is due to hydroxychloroquine rash exanthematous pustulosis. And just recently I saw toxic epidermal necrolysis with the hydroxychloroquine. Fortunately, we see these rashes less commonly. Stevens-Johnson syndrome can be due to any of the drugs that we use, but more commonly seen with sulfasalazine. Again, steroid striae, steroid-induced purpura, bruising and thinning of the skin. Methotrexate can cause alopecia, and due to immunosuppression, they can have rashes such as herpes zoster due to secondary infection. Erythema avignei, again, is very commonly seen in our clinics. Here they use applied heat for pain and more commonly seen on the knees and the back. Finally, I would like to reiterate, rheumatology and dermatology are very interrelated specialties, and we need to think a little bit just outside our own specialty in order to clinch the diagnosis early. I'd like to thank our medical photography department for getting photographs of the hospital and my registrar, Dr. Moore, for helping me with some of the cutaneous vasculitis slides. Thank you for listening.
Thank you, Dr. Srinivasan. That was an excellent description of skin manifestations and rheumatological problems. The skin being the largest organ. Can you stop sharing the screen?
Sorry?
Can you stop sharing the screen? You can see us?
Okay, I can do that.
Can you see us?
Yes, I'll just get you. Yeah? Okay, I can now.
Okay. Our skin being the largest organ gives a rheumatologist so much of scope and clues to make a systemic diagnosis. And sitting in the dermatology forum, I'm sure you will agree with what I say, especially to the younger dermatologists, to look beyond the skin. Just making a diagnosis of cutaneous vasculitis doesn't mean anything. Actually, there was an excellent lecture this morning by Professor Jacob Thomas on vasculitis, and the whole thing will go waste if, as a dermatologist, you don't look beyond the skin. I'm sure you agree with that.
Yes, I mean, I agree entirely, actually. Yes, there's a lot more, especially when you see skin lesion, particularly with vasculitis. I think we tend to look further, deeper.
Right. Any questions for Dr.
I didn't possibly get the question very correctly. Can you just, is it a question for me? I didn't get it.
No. I was just making a statement and asking you, do you agree with it?
That's what I thought you did, yeah. Thank you.
Any questions for Dr. Srinivasan?
Sister was diagnosed with rheumatoid arthritis by Dr. Chandrasekhar, and then she developed digital ulcers, and he said it was psoriasis, and we didn't proceed with it, and she was going on treated as rheumatoid arthritis. 10 years later she had systemic sclerosis. So psoriasis, do you get digital ulcers?
No, I'm not particularly seeing digital ulcers with psoriasis, no. Digital ulcers can be part of vasculitis, which we see in rheumatoid arthritis. Again, it is not commonly seen, but it can be part of vasculitis. But I have not particularly seen digital ulcers with psoriatic arthritis.
I think you said she's recently been diagnosed with scleroderma. Yeah, that was the early manifestation which was